want to thank Dr. Thomas Bilski for allowing Rowe Dental Laboratory to come and film and document his Chrome case today. Dr. Bilski is a longtime Chrome user. He is a teacher of implant placements at the Midwest Implant Institute and also mentoring in his office on implant placement, and just has a lot of experience. So thank you again as we go through this double arch case. This is a double arch maxillary edentulous mandibular dentate case, and we will document the entire procedure start to finish. As with all cases, they start with pin guides. Now when it's an edentulous against the dentate, that means the edentulous arch has teeth indented into the occlusion so that the opposing arch can be aligned. We'll explain this later. That's why these pin guides look a little bit different. Here they are articulated. You can see that the maxillary goes first into the patient's existing teeth. Here are the fixation bases showing bone reduction, carrier guides. Every implant on this case is angled, which made it very challenging. Prosthetics, and then finally the rapid appliances. This case was lengthy, and so the rapid appliances were not picked up. Okay, let's begin. Whenever there is a double arch and one arch is edentulous and the opposing is dentate, you always complete the edentulous arch first, because the pin guide is designed with occlusion to accept the opposing dentition, which means the first step is to try in the pin guide without the fixation base. You seat the pin guide, you ensure that there is no rock, that it fully seats on the tissue, and that the opposing teeth meet the occlusion perfectly. If there are any adjustments needed to make sure that the pin guide is fully seated, treat it just like a denture and make some minor adjustments. Once it's fully seated, then remove the pin guide and attach the fixation base to the pin guide, and then reinsert and put the patient in occlusion. Now the video that we're watching has already progressed beyond this stage. But you can see at this point the pin guide has delivered the fixation base. During the delivery process, the pin guide is held into place by the opposing teeth, and the assistant essentially holds the mandible to the maxilla with hands during the drilling phase of the pins. During that phase, with the pin guide seated and the fixation base attached, you drill one site at a time and place a pin. The purpose of this is to ensure that there is a perfect seating of the pin guide. If the pin guide moves at all during that step, then the fixation base will not be seated in the proper place, which means all the subsequent items that are placed into the fixation base will be off. So the pin guide must go in perfectly. Once all the sites are drilled and the pins are firmly holding the fixation base in place, then the pin guide is removed, and we pick up on the video here. Dr. Bilski opts to put the pins directly through the tissue and then lay a flap to remove all the tissue from the top of the fixation base and essentially flap lingually. There are a few options. Some doctors opt to seat the pin guide to make sure it fits, and then lay a flap from the ridge forward, and then seat the fixation base directly to bone, not through tissue. However, this has become a much more popular method of seating the fixation base by putting the pins directly through the tissue. Dr. Bilski uses the Keystone Prima fully guided kit. Fully guided meaning that the implant can be placed through the spoon system. Half the systems don't allow the implant to be placed through the guide, which means hand placement and hand tightening and hand judgment of depth. Not always the best option for this type of case. Fully guided kits are superior. So with the tissue flapped, the next step is to reduce the bone down to the level of the fixation base. Now this was an edentulous maxillary arch, so generally in those cases there's a limited amount of bone reduction needed. Dr. Bilski uses a very aggressive burr, which we're happy to supply the part number and manufacturer of that burr, but very aggressive, and so bone reduction only takes a few minutes for him in this arch. Another note on this stage, because it's minimal reduction, the flap is not extensive, but on many cases, especially when there's a lot of bone reduction, a lot of tissue to be moved out of the way, there's a suture that's placed to hold the tissue back into the palate or in the mandible as well. With the bone reduced, it is now time to start drilling the osteotomy sites. In this case, this is a challenging case for many reasons you'll see as we progress through this, but in the anterior, 8 and 9 were designed divergently and aiming towards each other, and so there are a few separate guides to use because of the proximity of the sleeves. So this is the first guide, drilling the sites for number 9. The case involves a very narrow ridge in the maxilla, so the doctor uses only a pilot drill and then osteotomes to spread the bone.
They're all 3-5.
Excuse me.
The 3-5
Osteotomy. Yeah.
This is a 2.5.
Yeah. We're going 20 millimeters.
Love the osteotome. And then doctor uses a final twist just to make sure that the osteotomy is the right size, shape. And then next is placing the implants. As I mentioned before, this particular guide is a fully guided kit. Therefore, the osteotomy guide stays in the mouth, set on the fixation base while the implant's placed. We will periodically speed the time up of this video, but the implant is placed, and then if torqued out through the motor, then hand tightened to depth.
And that looks nice.
Yep, very nice. Nice spot.
Good?
With the first site drilled, the osteotomy guide is removed and the second osteotomy guide is placed. This will include number 8 and then the 2 distal implants. So at this point it's repeat mode, business as usual. And Dr. Bilski will begin with the posterior implants, go through the same sequencing: pilot drill, osteotomes, and then twist drill, and then place the implants. Here is more audio on the osteotome procedure.
Okay, turn away from us. And I want you to point your chin up to the sky, please. Good, good, good. Okay, so I'm going to get a good hold here. Okay, go ahead. See the line? I'm going to look at the line, you look at the end. Go. Stop. It was a little soft. Yeah. Go ahead, one tap. It's light. Good. There's nothing there, so alright. Stop. 1, 2. 1, 2. 1, 2. 1, 2. 1, 2. 1, 2. Good. 1, 2. 1, 2.
Get the density.
So it's right up against that cortical plate. See what it just feels like going in there.
With the implants in, the multi-unit abutment seated, and now temporary cylinders have been added, and just as planned, the 8 and 9 position temporary cylinders are close, not touching, but they're close, which means that there does need to be a little modification to the prosthetic just to open up the entire trough to pick up the 2 temporary cylinders. But things are going according to plan. And so the prosthetic is adjusted, cleaned, a little bit of polishing, and then just to make sure that there's adequate space between the 2 temporary cylinders, they're adjusted. The blockout gaskets are seated over the carrier guide. These help to prevent any flow of the voco material or stellar material or some other material that you use to pick up the prosthetic, to make sure that it does not flow down below the carrier guide and lock in the prosthetic. That is very important to use blockout. We also supply the blue plug blockouts if you purchase our fixation kit, our prosthetic conversion kit. And then the voco is simply filled in the voids to connect the prosthetic to the temporary cylinders. And that is the extent of the prosthetic conversion. It's a very simplified process, just a matter of minutes, and then the prosthetic is ready to be unscrewed and finished. Once the luting material is set, the prosthetic is then removed and taken back into the laboratory and finished. And we'll go through the details of that in just a minute. With the prosthetic removed, the conversion is, as mentioned before, a very simple process. The green gaskets are removed, the prosthetic is cleaned and dried back in the laboratory. And while the prosthetic is being converted, the doctor removes the fixation base and pins, and then performs the suturing of the tissue and perhaps some tissue punch, which we'll cover in just a minute. The prosthetic conversion, if using the voco material, is completed in a dry environment. The adhesive is placed carefully around every area that's going to have some more voco added to it. Any void on the intaglio should be filled. It's important that the material not rise as a slope all the way to the top of the temporary cylinder. You do not want to have to blanch or displace tissue when inserting it in the mouth. So just add material so that it's flush with the prosthetic, and perhaps performs a little bit of blockout on the necks of the temporary cylinders, but not all the way to the top of the temporary cylinder.
Because this case involved a full flap over to the lingual, that means when the flap is brought back forward, a tissue punch will be needed to punch holes just over the multi-unit abutments. Another reason to make a large flap, so that you don't have stitches along the ridge, but rather a comfortable flap. It also helps with tissue sloughing as the patient's healing. The prosthetic is ready to be inserted. The little holes were also filled where the prosthetic connects to the carrier guide, and now the doctor will follow normal procedures for suturing and for tissue punch, and then the prosthetic is inserted.
It's verified that no tissue is holding the prosthetic up. That's obviously very important. The screws are hand tightened. A couple of them are torqued in and the others are just hand tightened. It's a little sensitive on the posterior implants with the osteotomes, and doctor actually tapped in the implants a little bit.
Just do a smile for arch number 1. The upper
I don't know
smile.
if she can
Yes, you
smile. Her
can.
lips not working.
We're numb. We're numb.
Yeah. Why it's just that.
Oh
There you
my
go.
gosh.
That's nice.
Oh, that's just great.
That's
Now the mandibular arch is performed. This arch is dentate. That means the pin guide is seated on the teeth, and it is confirmed that there is no rock, that there are no gaps, that the teeth meet the windows on the pin guide to ensure full seating. The doctor now, with the pin guide held firmly in place by the assistant or the doctor, the pin sites are drilled one at a time, and the pin is seated. Now, in this particular case, when doctor drilled the first, the drill dropped in too quickly and easily, and the pin just pushed in with finger pressure. So on the next 3 sites, doctor drilled only 3/4 and then used a surgical mallet to force the pins all the way to the cortical plate. This is very important. Although it's not ideal, it's not very comfortable for the patient, the pins must be firmly seated in bone so that the fixation base does not move during the surgery. This is more often seen in the maxilla than the mandible, but sometimes in the mandible. So with all the sites drilled and the pins placed, then the pin guide will be removed. You'll notice in this case, doctor uses Neosporin on the pins. It's a nice technique. With the pin guide removed, it exposes the teeth and bone that will be removed. Dr. Bilski has a little different technique than what is normally taught, and this is a technique that is perfectly acceptable. The tissue is flapped lingually, just like the upper, and it is flapped from the top of the fixation base. Many doctors lay a flap labially before the fixation base is seated. In this case, there's quite a bit of bone reduction, and so there will be plenty of tissue to work with from the lingual side. Next, the teeth are removed, and then the tissue will be flapped. Now, some doctors use rangiers and then a burr to grind the teeth down. We have some doctors who purchase a surgical saw and just remove the entire section with teeth included. That's a preference on the doctor's side.
So what we're doing here is we're releasing the labial tissue. The soft tissue profile is very thin because it's periodontally involved. So do you really want to use the same tissue when you know you're going to be bone reducing, removing tooth fragments?
Yeah, therefore, just a incision right across the fixation base makes perfect sense.
Yeah. And then, you can argue if it takes longer or not. I don't know. I don't think it does, but certainly on the end of suturing, it eliminates a lot of. It just kind of flips over.
Especially if you're on you're down on the floor of the mouth, right?
Yeah, you got to be careful on this lingual tissue. You don't want to deglove it, and now your tongue doesn't work, right?
Right.
Good voice, yeah. He was in. And then ends up in his office. He's got to fix it.
Right.
With the teeth extracted, the doctor now works on the roots and then completes the full bone reduction down to the level of the fixation base. It's very important that the bone is reduced to the level. In other words, you can use your finger and your gloved finger, and you can work your finger from the fixation base back to the bone and make sure there's a smooth transition. There's no humps. There's no sharp edges on the buccal or lingual as it approaches the bone reduction flat ridge. And once it's flat, then the carrier guide can be seated and tried in to make sure that there is nothing that is obstructing the carrier guide seating past passively. In other words, there's no tissue, there's no bone, there's nothing holding it up, which is key to supporting the carrier guide and subsequent prosthetic and rapid appliance.
What do we get on all these?
All of the final drill lengths are 23. This goes to 25 and a half.
Well, I can't push this in, this thing's moving. But, guide.
So the next phase is to drill all the sites for the mandible. So the doctor has the osteotomy guide seated. He has his pilot spoon inserted, and he's going to go through the sequence, which is the pilot site on each, the pilot used on each implant site, and then the next size up drill will be used. In this case, I believe we're just using 2 drills, the pilot and then a twist. On 3 of the implants, and then a larger drill on 1 of the implants. And then the implants are seated through the guide. Notice in this case, as with all chrome cases, the visibility of this system. You can watch the implant go all the way down to the bone. You can irrigate and visualize the entire process. The implant placement, the drilling, you can watch out for errors with trajectory. You know exactly when the implant should stop drilling. You can make modifications based on thread exposure and bone reduction issues. This design, along with many other attributes, make it far superior to the plastic guide systems out there on the market. With the implant seated, now the multi-unit abutments need to be added. All the implants in this case are angled, which means that all the multi-unit abutments are 17 and 30 degree. Makes it very challenging, and we highly recommend purchasing a contra-angle driver with a torque. You can contact Roe about this item. Working with the driver and the torque wrench is simple in the anterior, but in the posterior it can be very challenging, especially if you have large fingers, large hands. And a contra-angle driver is just a lifesaver in angled posterior situations. So again, fast forward, the multi-unit abutments are in, the temporary cylinders have been placed, and now the prosthetic is to be inserted. Now, this was a challenging case. It was a deep closed bite, maxillary denture, soft palate seating of a pin guide, which makes overall challenging. And this bite was a little bit off at the mandibular seating, and so we used a shim technique in which we just kind of wedged some blue blockouts underneath the prosthetic just to bring it up a little bit into occlusion, as opposed to decimating all the occlusion on the lower or upper in order to make the bite right. So a little bit of adjustment, and the bite is on, and the mandibular prosthetic is picked up, and then just as the upper, it's taken back in the laboratory and finished in just a few minutes. Once the material is set, all the screws are removed and the pins are removed from the fixation base, and the entire prosthetic and chrome guided system can come out at the same time. They're separated. The holes to the temporary cylinders are plugged with the little blue plugs, and then the appliance is dried thoroughly. Use adhesive to treat all the areas that are going to receive some more Voco material. Not all materials need an adhesive. Voco does. It's very important. Apply it. Use some air to dry it, and then fill in all the voids with the Voco. And Voco is 1 minute and 20 seconds to seat, or rather to cure. And it's important that the instructions are followed, because Voco comes in light cure, and it also comes in a self-cure. We always send the self-cure with a case, so no light needed. In fact, a light will not advance curing at all. So once the holes are all filled, it is adjusted, polished if needed, and then inserted. And during the process of this conversion back to the laboratory, again, just like the maxillary, the tissue is sutured and the patient is waits comfortably while the prosthetic comes out. And actually, normally, the suturing takes much longer than the prosthetic conversion in the laboratory. This is just a 10, maybe 15-minute procedure that either the laboratory or the assistant can perform. One of the goals with Chrome is that the laboratory does not have to come to surgery, and that these simple conversion steps are taught to the staff, and then you no longer need a laboratory and the expense of a laboratory chairside. And again, while the prosthetic is being converted, the patient is now, in this case, receiving bone grafting, and suturing is completed.
Little smile or big smile?
A big smile. Oh my gosh.
Nice. That is beautiful.
So we just finished your upper teeth. So you're wearing your provisional bridge. We call perma bridge. This is a Chrome smile. How you feeling after you have
Good.
this procedure?
Very well.
All right. So if you were to talk to somebody on the street and they said your teeth look beautiful, and then you start chatting a little bit more about what you had to do, is this something you think now, shortly after, you might recommend to a friend or a family member?
Yes.
Yeah. Okay. No. Hey, that's a normal response. I
Yeah, there
wouldn't
was
expect.
pain, but it was okay. You numbed it and everything was good.
Okay, good. So comfortable, even though it's an arduous task and it took a while.
Yeah, it was okay. I'm glad I have the results.
Okay, good. Because you look great. You don't look like you went through much, even though you know you did. And three and a half hours later, we got something.
Well, I never had a dentist spend so much time. You two are floating. You were staying by my side. I love
Absolutely.
that.
Okay, good. We try to do that. Well, this is a relationship-based practice. We're trying to get you better, trying to help you.
Yeah,
We're not
you
giving
stay
up
with
on
your
it.
patients. I like that.
Good. Thank you. Appreciate the kind words. Yeah.
And what's next? What are we doing now?
So now I'm going to lay you back, and we're going to get you numb, and we're going to do the bottom.
Oh, God, help me. I'm just worried about the teeth pulled and then all of the pain after, you know.
Most people do worry about that. It's very common. It's a big fear and anxiety. The Novocaine, like you already mentioned, you thought it was going to be painful. We got you numb, and you didn't really experience
No, yeah.
anything. The lower is going to even be more numb. So the biggest complaint from our patients is, geez, doc, I'm super numb. I can't even talk. And we call you the next day and find out that you're not numb anymore, you're feeling good. And most people on a scale of 1 to 10 will tell us day 1, day 2, and day 3 after the appointment, they're kind of hanging out at number 2, number 3 on a scale of pain, 1 to 10, 10 being painful. They're at a 2 or a 3.
Now, when you pull the teeth, are you going to put the implants where you're pulling?
So the engineers over at Road Dental and I sat together, and we're going to take the teeth out and smooth the areas that are kind of irregular.
Mm-hmm.
And then we've already identified, if you will, the areas where the implants will go in. Some may go into existing tooth spots,
Okay.
and some may go in what is called a healed site.
Okay.
So it doesn't really matter.
I
But
just wondered.
so it may go in a couple areas, and then may go into some healed sites.
Okay.
You ready to do this?
Mhm.
All right, good.
I
I'm gonna
gotta
lay you
straighten
back.
out